Who has worked around the world. Many of us have known him for a long time. Dr. Perry and I knew Tim at the Harvard School of Public Health. He was a postdoctoral researcher in the lab of Dr. Mitchell earlier in his career. He's held positions in a variety of places around the United States. He's been a department chair at Montana State University, a dean at Shenandoah University. Now he's at UMass Amherst. But one of the things that he's done is in his career is really worked in many places around the world. And what he's going to talk to us today about are some of the global challenges that he sees in water and health. So Tim, welcome.
Thank you, George. It's such a pleasure to be here. I'm really enjoying this warm weather because where I've come down from, we have been frozen for months, it seems. Just thawing out. I was sitting in Washington Square this morning, just lapping in the sun. Anyway, thank you very much for inviting me. It's, I say it is a pleasure to be here, and I'm going to talk about some of the global challenges, so feel free to interrupt me as we go along. It's a small enough audience if you have questions. I wasn't quite sure what exact level I should pose this, so it's fairly general, but we can get into some more specifics, perhaps during questions. I probably have too many slides, which is a bad habit of many of us these days.
Now it should work.
Yeah. Interesting. The pointer works on the wall, not on the
Oh, the
screen.
pointer will not this.
Oh, okay. But that
Is the advantage?
There we go. All right. So basically, what I want to do today is just very briefly highlight the problem of water and health. Focus a little bit on cholera because that's obviously a disease. It's very closely associated with contaminated water. It's a huge issue right at the moment in many parts of the world. Briefly mention, actually probably just focus on one study in India on water and health, which exemplifies the problem that many of us have in terms of doing research globally and how work can be sustainable. I'll talk a little bit about sustainability and the importance of community engagement in any research project in relation to environmental health, particularly in water, and some of the future directions. I've been an administrator for a number of years, so just stepping back into the research environment. So, some of the stuff I'll talk about at the end is quite new, and you'll probably know more about it than I do. So I'm looking forward to your input on that. So the burden of disease from contaminated water, this is probably data that you're all fairly familiar with. Mortality estimates have decreased. We are doing a little bit better. But the number of diarrheal deaths is still very large. And think about it, 500,000 approximately of these are children under the age of 5, which is also probably a fairly dramatic underestimate of the actual level of the burden. And there are millions of people infected with water-related diseases. When you think about infectious diseases, off-quoted figure again, approximately 80% are in some way related to water. When you think of all the vector-borne diseases that have vectors, mosquitoes, for example, that depend on water for their life cycles, all of these are preventable. That's really the key, that we have this huge burden of waterborne and water-related diseases that are actually preventable with fairly easy solutions. Water sources have improved since 1990. These are Millennium Development Goals. 2 billion have gained access, and we're beginning to meet those goals. But there's still a lot of people around the world that do lack access to improved water sources. In terms of sanitation, we've improved there as well. Almost 2 billion people have gained access to improved sanitation, in other words, collection of wastes from around the home. But 2.5 billion still lack access. 37% of the population lack access to improved sanitation, and over 1 billion people still practice open defecation. So we're seeing some improvements, but we're also seeing a lot of challenges. And those challenges relate to a number of areas. Obviously, climate change is something of major concern in relation to water and health. And you think about what happened to Puerto Rico, and leptospirosis outbreaks have happened there. Frankly, I'm surprised that we've not seen cholera outbreaks in Puerto Rico, because when you see that level of breakdown in infrastructure, then waterborne diseases in particular emerge, and vector-borne diseases too. So some of the other areas of concern: sea level rise and saltwater intrusion, resulting or exacerbating water scarcity for coastal areas, increased rainfall and snowmelt overwhelming combined sewer overflows, septic systems, etc. So a lot of sewage contamination of surface waters, and the increasing temperatures change the whole pathogen survival dynamics and their vectors as well. So back to cholera. Scourge of the past, obviously not if you've been following the news at all over the last few months. You'll realize it's not a scourge of the past. Anybody know who this guy is?
John Smith?
Almost the right answer. That's the answer I usually get, and it's a trick question. It's a very unkind question. This is my great ×4 grandfather. I've been transcribing his memoirs from the 1800s. And what I find most fascinating about this, and his quote goes on to talk about India and other countries around the world, was that oral rehydration therapy, in other words, the use of salts as a cure for cholera, was something that was known back in the 1800s. There's a lot more involved. But, everyone says it's John Snow. It's not. It's my great-great-granddad. Well, obviously, cholera is still a huge issue, and in some cases, it's due to severe weather events or major disasters. And obviously, the earthquake in Haiti in 2010 has resulted in cholera to an extent that's not been there for over 100 years. We're looking at nearly 1 million people ill from cholera, nearly 10,000 deaths from cholera in Haiti. And I will come back to Haiti since we're doing a little work there later in the talk. And then we've got places like Yemen, where we have human-induced disaster. There's nothing climate associated with this. This is purely politics, where we now have exceeded, in about a 6 to 8 month period, we've exceeded the number of ill and dying in Yemen from cholera than we had over a 4 or 5 year period in Haiti. And this is really all to do with internal conflict, international conflict. These are just some of the factors that happened. Sanitation workers were on strike, the government stopped funding public health and healthcare, and this has resulted in this enormous humanitarian crisis in relation to diseases like cholera. So we can cause it ourselves. And again, it's a breakdown in infrastructure, whether it's a geopolitical issue or whether it's climate change or some other disaster-related cause. So major outbreaks like Haiti, we can talk about the actual cause of cholera in Haiti later if you want to. That's an interesting area of discussion at the moment. But there's a tremendous level of endemic disease as well. And it's the levels of endemic disease that contribute significantly to the global burden of disease. So how do you make the epidemiological link between human disease and water in order to inform policy decisions? Primarily because there are multiple routes of exposure. Most of the infections, most of the diseases that we can, that are transmitted through water, are also transmitted by food, are transmitted by person to person, by the fecal-oral route and other routes, even through aerosols. So it's very difficult to know. I mean, this is just some examples of earlier work in India, spraying highly polluted water, people washing dishes, washing clothes on the streets. All these are potential routes of exposure to contaminants, including pathogens in water. Now, I had to show this slide for Ralph's benefit, because he probably remembers the background attributed to Greg Coburn. It's one of those slides we used to use in the 1980s of a highly corroded pipe. But it makes a nice backdrop for this. We depend on officially reported data for policy decisions. And that officially reported data, you know, you may have some treated sample analysis, you may have some source water samples. Maybe if someone's sick, there's a physician visit, and it's possible the physician makes a specific diagnosis that then gets reported. That can often be hundreds of fold smaller than the actual incidence of disease. So our approach has been to actually engage with communities to find out what people self-report in terms of incidence of diarrheal and other diseases. And you know, this is asking questions about different exposure pathways, other risk factors, asking about family member incidence of sickness, etc., and taking point of use water samples as well for analysis, and not just relying on the officially reported data. And again, you know, this kind of information provides us with a much clearer idea of the actual burden of endemic disease that we can't see from that officially reported data. Here's just an example of, you can't see his name, my doctoral student Andrei Agorov did some work in Russia, published in the early 2000s. And well, this is a temporal exposure response surface, which looks at self-reported rates of gastrointestinal diseases related to a water quality indicator, a very crude water quality indicator, in this case turbidity, given a lag time. When you ingest a pathogen, obviously it takes a while, depending on the type of pathogen, for you to develop sickness. So if you look at this, we have a spike in turbidity, shown here, after about a 2-day lag, related to a spike in gastrointestinal diseases. And that's consistent with viral diseases. We have another spike consistent with protozoan diseases. So these are incidents of disease in this community of Cherepovets in Russia, that were never reported as waterborne diseases. We went on to find that most fecal samples that we took from hospital patients in Cherepovets were actually positive for cryptosporidium, which at the time people denied ever actually existing, the existence of cryptosporidium in Russia. They also denied the existence of HIV. So here's another example of looking at community incidents, and this is really the socioeconomic association with disease. This is in Hyderabad in India. Another student of ours, Satish Mohanty, did this work and published in 2002, showing that with increasing socioeconomic status, there's a decrease in disease. And this is all, again, self-reported incidents. There's typhoid, hepatitis A, and what most waterborne disease ends up being, acute gastrointestinal infections of unknown etiology. Very little of it ever actually gets diagnosed. And in each of these cases, these are several hundred-fold times the officially reported data. And this is a study we did with Steve Hamner, my research associate at the time, actually while I was in Montana, published in 2006, looking at uses of water and pollution of the Ganges River in Varanasi, the city of Varanasi in India. Some of the pictures, you know, of the Ganges River here, juxtaposed with this standpipe. Here, you know, we've got these kids reporting that the well water is often contaminated with worms, with nematode worms, or what different pathogens are in there. But essentially, the well water is being drawn up from aquifers that are connected with the Ganges River. Sewage treatment is grossly inadequate in Varanasi. Probably the sewage treatment is capable of treating about 25 to 30% of the sewage generated within the city. And the rest of it just flows directly out into the Ganges River. It's very much a multiple use environment. You've got people washing, brushing teeth, etc., bathing, washing dishes, being shared with livestock, and that's the carcass of a cow actually floating down there with somebody washing right next to it. So a lot of opportunity for exposure to infectious agents from the river water. And when we took water samples, we found that you would anticipate that the fecal coliform levels, the indicators of sewage pollution, extremely high, over 1 million colony-forming units per 100 mil. We also found the highly toxigenic E. coli 0157, which you're all familiar with 0157, right? The cause of hemolytic uremic syndrome, a very severe form of E. coli infection. This is actually my research associate Steve Hamner taking a sample of the Ganges River water without a glove. He came back to Bozeman, Montana and was sick for about 2 months. Now, I'm not saying that this was directly the cause of the sickness, but it is an indicator that it's a good idea to wear protective clothing when sampling in these kind of environments. And this is just some of the data collected there. This is the Ganges River flowing through the city of Varanasi. Down here at Sarai Mohana, that's the sort of the slum area, or the worst slum area, should we say, in the city. There's sewage, raw sewage going into the Ganges all the way through here. And as you go down through the city, there's an increase of this acute gastrointestinal infections and the appearance of cholera. About 50% of these cholera cases were fatal. And none of them reported to any kind of official data sets or hospital incidence data. So again, this is all self-reported by community members. There's some of these significant risk factors for disease. Again, these are risk factors you might anticipate. Use of the Ganges for bathing and laundry, washing utensils, brushing teeth, and some of the socioeconomic factors, open defecation, lack of toilets and sewerage, low income and education, all correlated with levels of disease. But what's the point of this data? I mean, how does it help the communities? Well, our original plan, our hope, was that we work with the Sankat Mochan Foundation. This is a foundation established in Varanasi with the mission to clean up the river Ganges and to increase political will for wastewater treatment. So we were told at the end of this study that they were going to increase capacity for wastewater treatment and that better quality wastewater treatment and removal of sewage from around homes would be put in place. Very little of that has actually happened. This is a really disappointing part about these kind of projects. They don't take into account the culture of the communities. They don't engage the communities sufficiently. And you see this time and time again with studies on water, sanitation, and health, that we go in, we make recommendations, and they are never adopted. They're never sustainable. Here are some of the problems that I've noticed. And this is I think a World Bank project installing latrines that were never used, because the community weren't engaged in the discussion. You build a pit latrine. It's dark, it's small, it's smelly. You have to pay a rupee to use it, and so none of the children would go near these things. They're terrifying, and so they're never used. Some of the communities that we work with were wondering, you may have seen the picture earlier of the boy playing in the river. That's the Musi River in Hyderabad. Highly contaminated, 100% sewage flow for most of the year, except during the rainy season. And they were wondering why we were concerned about water quality when people were unable to sleep. They were bitten by mosquitoes all night long. So again, some of the priorities of the community are not taken into account In Russia, it's actually after our work in Chernobyl, it's a French company, moved in and installed at great expense ozonation, but didn't train anybody how to use it, didn't provide any maintenance for the equipment, and to my knowledge, it never actually got used. Suggesting behavioral changes that are culturally unacceptable. And after you've done some work on a place like the Ganges River, then the natural response is maybe you should stop this religious bathing because you're essentially ingesting huge numbers of extremely virulent pathogens. But that's not acceptable. That's not a culturally acceptable recommendation. So that brings me to some work that we started to do following this work in India and following the disappointments of not being able to really affect any changes in these places. This is work on the Crow Reservation in Montana, and it's exposure assessment work. Here we focus primarily on community-based participatory research. Is that something everyone's familiar with? With the CBPR methodology, we build trust by spending a lot of time listening to communities, being prepared to, Montana's a big state. Where we are down in Bozeman, or where we were down in Bozeman, still like to think I'm there sometimes. One of our reservations was Fort Peck, a good 9-hour drive. And if they wanted to meet with us to discuss anything, then I would drive to Fort Peck and sometimes drive back the same day. You try and fit 2 9-hour drives into one day. And sometimes you'd go to a meeting, you'd sit there and listen, and they wouldn't ask you to speak. So you don't speak. Don't speak unless they ask you, invite you to speak. So again, it's being prepared to spend time and to listen to the concerns of the community. The community members very much lead the research, and Crow water was their primary concern. They're also part of the solution, and what we found with Crow is they were able to influence their political leaders by having them so integral to the project, having them on every publication, usually as first authors on the publications. And that's tough for PhD students in particular, because they have to take a step back with CBPR type of work and allow the community to drive the work. Anyway, the Crow Reservation is, like so many of the reservations throughout the US, exposed to a wide variety of different contaminants. There's uranium mining out here in the Paria Mountains, there's coal and methane extraction over in the Wolf Mountains, there's mercury being generated in Bighorn Lake, which is one of the fishing areas. There's a lot of agricultural runoff. One of the biggest issues with reservation lands throughout this country is that they are leased. They're often leased to white, non-native people who really don't care about the land and allow their wastes to run directly off into the surface waters, which are often the source waters for the communities. So we find E. coli, we actually found Helicobacter pylori and some other pathogens in the source waters for Crow Agency. There's also coal mining and power plants that are producing mercury as well. And unknown meth labs, unlined landfills, and oil exploration too. So a wide mix of environmental insults on the Crow Reservation. We assessed waterborne contaminants and the different exposure routes using some of the methods I mentioned briefly before, looking at river water, looking at fish, looking at home well water, analyzing springs, using surveys and really getting engaged with the community, but using tribal members to do that. So we worked directly with the tribal college, Crow Agency, the Little Bighorn College, and it's their students that would go out and talk to their community members and find out what the exposures are and what the major concerns of the communities are. And there's tremendous knowledge as well, talking to the elders of the communities who can really give you the historical context of the exposure and use of the environment. We hold training workshops at tribal colleges. So my lab manager at the time, Sid Broadway, teaching basic filtration and coliform enumeration there. Here are some of the tribal students out in the rivers taking samples. And, again, some of this sums up a huge amount of work, but the river water is contaminated, and so were the home wells. High levels of contamination. We also found very high levels of E. coli, and again, the enterotoxigenic E. coli 0157. These are just all contaminated wells along the Little Bighorn River and some of the other river systems in Crow. So that you then come to the question of how we communicate this information. And so we spend a lot of time working directly with the community, providing information pamphlets, talking about how wells can be cleaned up, how water that's used for religious practices, for ceremonial practices, can be kept a little bit safer. I mean, obviously, on the reservation, the sweat lodge is a very key, integral part of the culture, and raw river water is used in the sweat lodge, creating aerosols that can be inhaled. Some of this work was highlighted by the NIH and by the EPA, which was nice. But what was most gratifying, I think, was that the elders of the community were able to take this information and convince policymakers to raise funding for water and wastewater treatment. So this is our Crow Environmental Health Steering Committee at the groundbreaking of the wastewater treatment plant, new wastewater treatment plant. Prior to this wastewater treatment plant, all they used were sewage lagoons that would just overflow into the river whenever it rained. So what are we doing now, Crow? Any of you familiar with the MinIron? This is sort of a big leap into more new research directions. I have about another 10 minutes?
Yeah.
No, 15. Yes. What happened there? The MinIron, it's a little handheld whole genome sequencer that's produced by Oxford Nanopore Technologies in the UK. And what they've done is they've engaged a number of labs. Well, I say they've engaged us, we pay them quite a lot of money to be engaged with, to essentially beta test. They sell it as being something that's going to revolutionize our research. And really what we're doing is beta testing it. It needs a lot of optimization. But my research associate Steve, I spied one of these last year, and he's been doing some interesting work at Crow to try and find out a little bit more about the toxigenic pathogens that are present, particularly in the Crow swim hole. There's the Crow Fair. It's probably the largest Native American fair in the country. It attracts people worldwide. They all camp along the banks of the Little Bighorn River at the hottest time of the year there in August. All the children swim in this swim hole. And this is where we've been measuring 0157. Now, what is that? The trouble is we don't really know what that means in terms of risk. Just as we don't really know what it means when we get a high coliform count in terms of risk. We know the sewage contamination, but we're unable to make that direct link with disease. Now, what we do have is a lot of the parents complaining that their children have gastrointestinal problems after Crow Fair. Now, they're also eating a lot of food that may be poorly cooked as well. So again, knowing the exact route, we're uncertain. But we're using this sequencing, this whole genome sequencing, to try and understand a little bit more about the microbial makeup of the communities of these sites. And this just, again, sums up Steve's metagenomic profiling of the swim hole water. Gets a wide range of pathogens. And this is actually enriched water samples. So the water is actually first enriched with it's called coded blue, but it enriches for the coliform group of bacteria. So we're specifically looking at what's in that pool of potential pathogens. He's finding a variety of different enterohemorrhagic and enteropathogenic E. coli, and these are organisms like E. coli 0157, some rarer pathotypes as well, 0104, which caused a major disease outbreak in Europe. And he also found the Vibrio cholerae, 01 serotype, present in the swim hole. Now, to be honest with you, we can find Vibrio cholerae 01 in a lot of places we go. It's been isolated many times from the Chesapeake Bay. In this case, there's no cholera toxin converting phage, so it's probably not a health risk, since in order to produce the cholera toxin, the phage needs to be present. So that where we're trying to take this is what we need we call it a rapid, accurate, and actionable monitoring tool. We're trying to improve our ability to monitor for these different pathogens. Something that can be used in a fully equipped clinical laboratory, something that's suitable for a rural mobile backpack clinic, and something that could be field deployable for environmental monitoring and tracking. And the reason why we want to do this is for our work in Haiti, where many of the communities are only accessible by foot or on the back of a donkey. So extremely limited resources and no access to clinics. Cholera in Haiti, I alluded to this earlier. This is work we started with the PAHO Foundation, originally the Pan American Health Organization Foundation. They're now changing their name, they're dropping the PAHO for political reasons. But they are focused on a very wide range of health issues in Latin America and the Caribbean. So we've been working with them for the last 6 months or so. There are a number of elements to this, beyond just the metagenomic profiling, which I'll come back to. This is one of our students, Monica Roy and Jean Arnaud, is actually an undergraduate in our program, and I've sent them down to Haiti twice. They've been working with this group called the Midwives for Haiti. The whole point of this project is to improve surveillance and response to cholera in the region. Midwives for Haiti are an ideal group for us to work with because they serve pregnant women from throughout the country. They access through a mobile clinic many of these underserved areas that, again, say, only accessible on foot. And they provide pre- and postnatal health support. So we're working with them to help them administer the oral vaccine for cholera, but also engage their clients, the pregnant women, to go back to their villages and become part of that surveillance network, become more aware of cholera and other waterborne diseases and preparation of oral rehydration therapy to treat the diseases. Here's the other side of this work is to see what we can look at in terms of environmental samples. We want eventually to start looking at clinical samples as well, using that MinION whole genome sequencer. But right now, we're starting with, and this is very early on in this work, so I can't get too advanced with it yet, unfortunately. That's Jean sampling water for metagenomic analysis. Here are 3 of the key sites: Mirabelais, Beaumont, and I'm missing the name of the bottom one. It'll come up on the next slide. This is the one with most of the human activity and a fair amount of open defecation around the sides of the river too. Now, the data is interesting. I mean, this is not using the MinION. This is actually sending DNA samples back to the lab here and doing whole genome analysis. Well over 1,000 different bacteria. Of course, we're also looking at antimicrobial resistance genes, virulence genes, fungi, protozoa, etc. Just in terms of the bacteria, well over 1,000. And obviously, we're still mining this data, so we're not quite sure what it means. But there are a few red flags. I mean, the fact that the Legionellacea are there, the fact that Acinetobacter, Bowmanite, the Acinetobacters are fairly common contaminants of environmental samples, soils and water. But Boehmeni is probably the, about 80% of all Acinetobacter infections, hospital-acquired infections, are caused by this particular species. So its presence in many of the samples is of concern. These are the three. Mirabilis inchus is the epicenter of where we're doing the work. But it's a little hard to tell from this slide, but these are the three river sites, and these are the top 35% relative abundance. And there are significant differences between the three sites. With this is probably the obvious one to show. The green band is Sphingobium yanokii, and that really dominates this particular site. So we can begin to characterize each site based on the makeup of the primary pathogens that are present there. And here again, they're grouped by principal components analysis, again demonstrating that separation. Now we don't find Vibrio cholerae 01 in this particular group of samples, although we did find 01, the Chesapeake Bay strain and the endemic Haiti strain last summer when we took a look. But what was particularly interesting here was that most sites were getting sugar toxin converting phages. Now they're very important in terms of those toxigenic E. coli and Shigella species. And we also picked up Vibrio cholera converting phage, cholera toxin converting phage. So there is, again, a number of integral genes from Vibrio cholera too at each site. So what does that mean? How do we use this data for disease prediction and risk assessment? Well, let me just finish up. I mean, obviously we're still working through this data. We're trying to figure out what it all means. There's some red flags there in terms of the sugar toxin, cholera toxin converting phages. It's really trying to understand these different systems as clearly as possible in order to eventually predict risk. So I'm just going to finish with a little bit on satellite imagery. It seems like it's a completely different subject, off topic, but it's related. This is satellite imagery for cholera and sea surface temperature. This is some work we did a few years back with the Colwell's group, where we take this data to try and predict incidence of disease. And it's actually very powerful. It's being used more and more for a variety of different infectious diseases, including malaria. But this is shown for cholera, where we've got sea surface temperature, and Ralph and I were having this discussion a little bit earlier about the association of cholera with plankton, the ocean plankton. That with sea surface temperature, we have an increase in plankton growth in the oceans that are followed by zooplankton blooms. The Vibrio cholerae pathogen is associated with the zooplankton. Sea surface height reflects the potential for flooding, for coastal flooding. And this applies particularly to the Bangladesh area. And chlorophyll A levels, again, a reflection of the amount of phytoplankton. When you combine these together and using increasingly sophisticated algorithms to predict the likelihood of the incidence of cholera, which is shown down here. In green is the actual cholera incidence rate, and in yellow is the predicted rate. And the predictions are actually quite close. There's still work that needs to be done on those algorithms to make sure that they are accurately telling us what's going on the ground. And that's all part of this ground truthing process, which is where I think we can start to use some of that metagenomics information to tell us what potentially is a risk in terms of a toxin converting phage or a particular pathogen that we could pick up through whole genome sequencing. So here it's making sure that the parameters measured by satellite imaging actually reflect what's happening, whether it's in soil, water, or other environmental parameters. We look at what pathogens are present in those samples. So we need to understand the biology and ecology. They may have an intermittent host. So understanding the intermittent host biology is important as well, and the susceptibility. Acinetobacter boehmeni, which is this pathogen that is very closely related with hospital incidence of disease, is a significant problem for immunocompromised people. And if you've worked in Haiti, you'll know that HIV is highly prevalent in that country and remains highly prevalent. So you do have a very susceptible population, resulting in a predictive model of disease. Let me just finish off here. If you're able to predict in a 2-week time period, a month, maybe a 6-month time period, that you're likely to have an outbreak of something like cholera or another infectious disease, then you can intervene with some very simple means of intervention. I just highlighted Rita Colwell's work here with the sari cloth filtration, because she actually took satellite imaging data suggesting cholera outbreaks, future cholera outbreaks, and recommended to the communities that they fold multiple layers of sari cloth and filter the water through that sari cloth before ingesting the water. And that resulted in 50% decrease in cholera mortality, which is pretty significant for Bangladesh. So again, and these are just a whole range of different, simple, very simple interventions. If I go back, all the way back to the beginning of the talk, I've run through my time there, all of these diseases are preventable. And they can be preventable with very, very simple interventions to address sanitation and hygiene and sanitation. We don't need complicated, sophisticated water or wastewater treatment technology in most cases to address much of, well, I would say most of the global health challenges in relation to water. We need a certain amount of education, and we need to be able to provide simple interventions. Tools trying to figure out how we use this vast wealth of metagenomic data for prediction. We understand that it's critical that communities are engaged in every part of the work. We need to better define the risks and communicate those risks to those communities, support interventions that then inform policy. But ultimately, we want to see sustainable solutions like the building of a new wastewater treatment plant, a new water treatment plant at Crow Agency. That's the ultimate goal. Here are some of the people that have been involved in my projects over the years. My lab at Montana State University. You saw a couple of pictures of the people I have now at UMass Amherst, but I've not been able to get them together yet to take a group photograph. and again, these are some of our Crow colleagues and students from Montana, some of the different funding agencies. So thank you for your attention, and I'd be very happy to try and address any questions you might have.